Hello, everyone. Thank you for joining our webinar today. This is session 3 of the Common Psychiatric Conditions webinar series for Mind the Bleep. I'm Hannah. I'm one of the psychiatry co-leads for Mind the Bleep. And today we have Miles, who's a CT2 in psychiatry, and he's going to be taking us through this presentation. Also, please stay through till the end, where there's a feedback form, and you can also get a certificate. Thanks, Miles.
Thanks, Hannah. So yeah, like Hannah said, so I'm Miles, I'm a CT2. Today I will be presenting on mood disorders. Feel free to interrupt me if you've got any questions, and also we'll have some time at the end as well for questions as well. So in this presentation, I will define what mood disorders are, identify the main types of mood disorders, recognize clinical features of mood disorders, understand the basic assessment and management principles, as well as we will end with how to perform a risk assessment for mood disorders as well. So to start off with, what are mood disorders? So mood disorders are mental health conditions causing an intense disturbance in emotional state, going beyond the normal ups and downs of every day that we all experience. They cause a significant impairment in daily life, at work, at school, and with relationships both with family and with friends. Mood disturbance is persistent and pervasive, and there's a high comorbidity with anxiety, substance use, and also physical illness. So the main mood disorders that we will cover today are major depressive disorder, persistent depressive disorder, also known as dysthymia, premenstrual dysphoric disorder, PMDD, and then also we will discuss the bipolar disorders 1, 2, and 3, cyclothymic disorder, as well as mixed episodes. So in terms of depressive disorders, the core features of a depressive disorder is low mood and anhedonia, which is the loss of interest or pleasure in activities or things that we would usually be interested in. And these are present for most of the day, nearly every day. And then associated symptoms of a depressive disorder can be sleep disturbance, reduced energy, appetite or weight change, so that can be an increase or a decrease, poor concentration, a feeling of guiltiness or worthlessness, poor motivation, as well as suicidal ideation or thoughts of self-harm or actual self-harm. So a depressive episode is when these depressive symptoms last for 2 or more weeks, and there's a significant functional impairment. So that could be not being able to get to work, not being able to get out of bed, look after your personal care, and also an impairment in relationships as well. And there can't be any history of mania or hypomania, because that would be classed as bipolar, which we'll go into a bit later on. And a depressive episode can be mild, moderate, or severe. And it can, in severe cases, also have psychotic features, which can complicate it a bit. But this is a depression with psychotic features is when the psychotic symptoms are only present during the depressive episode. And the mood symptoms really come first, and they are more of a key feature in the episode. So just want to keep in your thoughts. So for a depressive episode, there's a 1-year prevalence is about 5% and a lifetime prevalence of 13%. The most common comorbidity is anxiety and also alcohol abuse. An untreated depressive episode usually lasts around 6 to 13 months, but it can be much longer, whereas a treated episode lasts around 3 months. 50% of patients who have an episode of depression will experience a recurrence within 5 years. Moving on to persistent depressive disorder, dysthymia. This is a chronic low mood, so the depressive symptoms are chronic and they last for 2 or more years. The symptoms may fluctuate throughout those 2 years, but they are persistent. And they may have superimposed major depressive episodes within that 2 years. So a constant chronic low mood with possible superimposed major depressive episodes within that. So this slide just indicates some good prognostic indicators and also some relapse indicators. So a good prognostic indicator would be if the depressive episode was mild, if the patient had a solid network around them, stable family, stable friends, if they had good social functioning before the illness, an absence of comorbid psychiatric disorders such as personality disorders, and no more than one previous hospitalization for depression. Whereas a relapse indicator would be if the episode was severe and if it was quite a lengthy episode as well. Another relapse indicator would be if the patient is quite isolated socially, if they had a poor baseline, if there's any evidence of persistent dysthymia, and if they had a partial remission. And there's just a few terms at the bottom here. So if a patient is symptom-free for 6 months after the acute period, that is classed as recovery. Any repeat of depressive episodes before the 6 months is known as a relapse, and any repeat after the 6 months is a recurrence. So in terms of treatment, for a mild depression, we would recommend what we call watchful waiting with lifestyle advice. And that lifestyle advice can be anything from talking about sleep hygiene, such as reducing screen time or going to bed at the usual hour, reducing caffeine, stopping substance use, exercising, journaling, anything like that, really. And then we would always advise to review again in 2 weeks' time. For mild to moderate depression, the first line would be CBT or counseling. And then for more moderate to severe depression, we'd be looking at CBT plus an antidepressant. So it's always good to advise patients that antidepressants can take 2 to 4 weeks to feel any effect, really, and up to 6 to 8 weeks to feel a full response. So it's always worthwhile mentioning that to patients before starting antidepressants. For a single episode of depression, we recommend continuing antidepressants for 6 to 9 months after the resolution of any symptoms. And we always aim to prescribe the lowest possible dose that is effective. SSRIs are first line, so I'm sure you would have heard of sertraline, fluoxetine, citalopram, escitalopram, are quite common SSRIs. Then there's SNRIs, such as venlafaxine or duloxetine. And then there is NASAs, such as mirtazapine, and then there are tricyclic antidepressants as well. Just something to keep in mind is when we would decide which antidepressant to go for. So like I said, SSRIs are first line, but after that, it really depends on what the symptoms and what the patient really wants. So for example, mirtazapine is quite a sedating antidepressant, and it also can cause weight gain. So if that is a bit of a no-go for some patients, then we would think about something else. Venlafaxine and duloxetine are good for neuropathic pain as well. So if you have a patient with chronic neuropathic pain, as well as depression, it could be worth thinking about using those. So for SSRIs, which are the most common antidepressant prescribed, some common side effects for them are GI upset, headaches, sexual dysfunction, and also an initial increase in anxiety. So for the first couple of weeks, it is quite common for people starting an SSRI to notice an increase in anxiety. So it's always worthwhile mentioning that to the patients before they start. In terms of risks to look out for, hyponatremia, especially in the elderly, as well as a risk of GI bleeding, which is increased if they are also taking NSAIDs. Another thing to look out for would be what we call serotonin syndrome. So this is when the patient can become agitated or confused, they can become hypothermic, they can be tachycardic, they can have clonus or muscle rigidity. And if necessary, they may need to go to A&E to get some IV fluids, possibly sedation, and in severe cases, temperature control, and possibly an admission to ICU. Moving on to treatment-resistant depression. So this is when a major depressive disorder or a major depressive episode has failed to respond to 2 or more adequate trials of antidepressants from different classes. And in terms of management approaches, there's the pharmacological option. So we could either augment that with lithium or an atypical antipsychotic, or we could use a combination therapy. So that would be SSRI and bupropion, or possibly venlafaxine and mirtazapine, which is also known as Californian rocket fuel, because it's quite there's a rapid and robust mood response seen when given together, but that would probably require specialist input. In terms of non-pharmacological interventions, we could look at ECT, so that would be electroconvulsive therapy. This has been shown to be most effective for severe or psychotic depression. It works quickly, and there's very high remission rates of 70 to 90%, so it has been shown to be very effective. There are some side effects, such as memory impairment and also transient confusion. For TMS, so transcranial magnetic stimulation, this is a non-invasive outpatient procedure. The patient would wear kind of a metal helmet with a magnet inside, and it can cause changes to brain activity patterns. And the patient would come for 5 days a week for around 4 to 6 weeks. And each session would last 30 minutes, and the patient can be awake. There's no anesthesia needed, unlike for ECT, where they do have to receive some anesthesia. TMS targets the left dorsolateral prefrontal cortex. It's usually very well tolerated with minimal cognitive side effects. Moving on to premenstrual dysphoric disorder, PMDD. This is a collection of psychological and somatic symptoms during the luteal phase of menstruation. Symptoms are cyclical and they're not persistent through the month. And they usually begin to improve within a few days of menstrual flow. Importantly, these symptoms and signs limit functioning either at work, at school, or socially. So that's the main thing, that they are having a big impact on the patient. And for the diagnosis, they need to have 5 of the following symptoms in most menstrual cycles during the last week of the luteal phase. So low mood, anxiety, anger or irritability, anhedonia, difficulty concentrating, lethargy, appetite changes, feeling overwhelmed, physical symptoms such as breast tenderness, headaches, MSK pain. And like I said, these symptoms have to limit functioning. And we recommend symptom tracking over 2 or more cycles. In terms of treatment, for mild PMDD, we would recommend lifestyle changes, hormonal contraceptives, CBT. And for more severe PMDD, we could look at SSRIs, and what we do is called intermittent dosing. So that's only dosing during the luteal phase, as well as possibly getting some gynecological input as well. There's something missing there, but moving on to postpartum depression. Won't be a second. So this affects around 10% of pregnancies. Baby blues, not to be confused with baby blues, which is very common. Up to 80% of people suffer from baby blues. This is when the symptoms are self-limiting and does not require medical treatment. And postpartum depression can begin during pregnancy or within weeks to months after delivery. In terms of treatment, so on the more mild side, we'd really look at supportive interventions such as sleep protection, social support, practical help, such as parenting or lactation support. For mild to moderate postpartum depression, we'd be looking at CBT or interpersonal therapy. For moderate to severe postpartum depression, would be thinking about medications. So SSRIs, with fluoxetine having the most evidence as being successful. We would recommend avoiding paroxetine just because this passes through the breast milk more, and that can lead to the baby having poor weight gain, irritability, as well as drowsiness. It's important always to screen for bipolar disorder before starting the antidepressants, and we would aim, if possible and if safe, to aim any medication until the second or third trimester. In severe cases, it might be necessary as well to have an inpatient stay at the mother-baby unit. In terms of postpartum depression, the prognosis is highly treatable, and early identification has been shown to improve outcomes for both the parent and the child. Moving on to bipolar disorders. So the diagnosis of bipolar disorders is based on the presence of manic or hypomanic episodes. I'll explain what those are in the next few slides. It is frequently misdiagnosed as unipolar depression, and treatment implications can be significant if it is misdiagnosed, as I'll explain in some later slides. So, what is mania? So it is defined as a persistently elevated, expansive, or irritable mood. There's increased activity or energy within the person. It should last at least several days, but if severe, it can be any duration. And there's usually a prodromal phase beforehand. And what a prodromal phase is, it's an early period before the full onset of the illness. It can be subtle, quite non-specific symptoms, such as poor sleep, some social withdrawal, an increase in anxiety, but it can vary from patient to patient. Some associated features of mania are reduced sleep, an increase in talkativeness or pressure of speech, racing thoughts, inflated self-esteem or grandiosity, some profound risk-taking behavior, whether that's gambling, whether that's unsafe sex or putting yourself in dangerous situations, and possibly some psychotic symptoms as well. So bipolar type 1 disorder. So this is where there is at least one manic episode. Depressive episodes are common, but they're not actually required for the diagnosis. And like I said previously, mania often causes significant impairment requiring a hospital admission. Treated mania usually recovers around 4 to 5 weeks, but you do notice some good recovery within the first week of treatment as well. The lifetime suicide risk is around 10%. 25% will attempt suicide, and 80% of these attempts are within the depressive episode. It's important to rule out substance-induced mania, as well as medical causes such as hypothyroidism or neurodisorders or other psychiatric disorders which could mimic some symptoms of bipolar. So in terms of the treatment of bipolar type 1 disorder, so if a patient presents in an acute manic phase, we would look initially to start an antipsychotic to get the mania under control. And that could be olanzapine, it could be risperidone, it could be quetiapine, or it could be haloperidol. Then more long-term would be thinking about mood stabilizers, so that could be lithium or valproate. And it's always important to stop any antidepressant if they are on an antidepressant. In terms of if they are quite agitated on the ward, it might be necessary to start a benzo, possibly PRN, so that could be lorazepam or it could be clonazepam. And like I said, if the symptoms are severe, if they're having a severe impact on their functioning, they may likely require hospitalization. For depressive episodes within a bipolar patient, we'd be looking more for mood stabilizers or antipsychotics. We would avoid antidepressant monotherapy just because there's a risk of inducing mania, but we can prescribe fluoxetine alongside olanzapine or quetiapine, but not as a monotherapy. Psychotherapy, such as CBT or psychoeducation, can also help prevent relapse as well of depressive episodes. In terms of maintenance or prevention of bipolar disorder type 1, long-term we'd be looking at mood stabilizers with lithium as the gold standard. We'd also be stressing the importance of psychoeducation, so explaining about the disease, about triggers, about relapses, about sleep hygiene, and early detection of any prodromal symptoms. And we'd also be advising to regularly monitor for suicide risk. So lithium is the gold standard for maintenance therapy for bipolar. It's important to do baseline checks before starting any patient on lithium. Important to look for user needs, thyroid levels, calcium levels, do a pregnancy test if any for any females of possible pregnancy age. Always important to do weight, get a BMI score as well as doing an ECG. And the monitoring during treatment, it's always important to get a lithium level 5 to 7 days after either starting lithium or changing the dose of lithium. And then once they're on a stable level, once they're on a stable dose, doing a lithium level every 3 months. The typical therapeutic range would be from 0.6 to 1 millimoles per liter for maintenance. However, if a patient presents in an acute manic phase, we'd be looking more at 0.8 to 1.2 millimoles per liter to get that acute mania under control. Then in terms of once the patient's stable, we'd be looking at doing user needs every 3 to 6 months, as well as thyroid function tests every 6 to 12 months, a bone profile annually, as well as doing weights and BMI testing as well as looking for any side effects as well every 6 months. In terms of warning signs, you'd want to be looking for any signs of lithium toxicity. So this can range. So a more mild form of lithium toxicity could be a fine tremor, diarrhea and vomiting, polyuria, polydipsia, ataxia, confusion, or blurred vision. On the more severe side of lithium toxicity, you'd be looking at hyperreflexia, hyperextension of limbs, seizures possibly, renal failure, severe dehydration, comatosation, and possibly death even. So it can be lethal, lithium toxicity. So it is worth looking out for, as well as regularly monitoring. In terms of drug interactions that can increase the risk of lithium toxicity, always be careful when prescribing NSAIDs, ACE inhibitors, and diuretics alongside lithium. And in patients who have diabetes, congestive heart failure, chronic kidney disease, schizophrenia, or Addison's disease, the risk of toxicity is also higher. Moving on to hypomania. So this is where the symptoms are similar to mania, but less severe. There's no psychotic symptoms, and there's no marked functional impairment in the patient. So they're able to function still, they're able to go to school, able to go to work. There's no social impairment really, but there is a clear change from baseline functioning. So it could be an increase in energy, reduction in sleep, slightly elevated mood, slightly racing thoughts, mild to medium risky behaviors. And hypomania usually lasts around 4 days. So for bipolar type 2 disorder, they would have a history of hypomanic episodes and depressive episodes, no history of full mania, otherwise that would be type 1 disorder. It can be often underdiagnosed bipolar type 2 just because patients often don't require hospitalization and so can go under the radar. The onset is in early adulthood and it is slightly more common in females. So in terms of treatment, usually acute hypomania doesn't require hospitalization. But if necessary, if it is causing any disruption or if it's distressing, you could think about starting a mood stabilizer or an atypical antipsychotic. For someone suffering from an acute depression in bipolar type 2 disorder, we'd again be looking at a mood stabilizer first, such as lithium or lamotrigine. Antidepressants can be used, but again, not monotherapy. So it would be with a mood stabilizer or with an antipsychotic to prevent triggering hypomania. In terms of maintenance or relapse prevention, we'd be looking, like I said, at long-term mood stabilizers, providing psychoeducation around sleep hygiene, also educating around early recognition of hypomanic or depressive prodromes, and regular follow-ups as well, depending on the patient. So on this slide, I just have a couple of other mood disorders that I thought might be worthwhile mentioning. So there's what we call cyclothymic disorder. So this is a chronic mood instability with numerous periods of sub-threshold hypomanic and depressive symptoms for more than 2 years. So this is where a patient might suffer from some manic, some depressive symptoms, but they're sub-threshold, so they're not quite meeting the criteria for bipolar, and it has to be for more than 2 years. Patients can also suffer what we call mixed episodes. So this is when they have simultaneous manic or hypomanic symptoms as well as depressive symptoms. So they often, over the course of a couple of weeks, they can have symptoms. So one day they might have manic symptoms, the next day they might have depressive symptoms, and it can just flip and flop throughout that period. And they often can present with agitation and mood lability. And it must be for a minimum of several days. And like I said, meeting the criteria for both either mania and depression or hypomania and depression. So like I mentioned earlier, bipolar type 3 disorder is not officially in ICD-11, but it is a known disorder, and it refers to bipolar-like symptoms that are induced either by antidepressants or substances. So just something worth keeping in mind. And finally, moving on to risk assessments, which are vitally important for patients suffering from mood disorders. It's always important to ask about suicidal ideation or thoughts of self-harm. It's normally best to do this in the latter half of the review, once rapport has been established and the patients are feeling a bit more comfortable discussing sensitive topics. In a manic patient, or a depressive patient, it's always important to ask about impulsive behavior, whether that's gambling, could be spending lots of money, could be having unsafe sex, or it could be any behavior really putting themselves in danger. It's always important to ask about risk to others. So whether if a patient's carrying a knife, or if they're making threats about any particular individual, or if there's any children or people that they care for, that's also important in someone suffering from a mood disorder. It's always important as well to ask about questions to see if there's any risk from other people. So if the patient is in a vulnerable situation, is someone taking advantage of them whilst they don't have capacity, or if they're in either a depressed state or a manic state. It's always good to get a timeline of events as well, and work out what the baseline of the patient is, how they function usually when they are well. It's always good as well to ask about protective factors, so whether they have any friends or family that they have around them, if they've got a good social support network. They might have a pet at home that they have to care for, that would also count as a protective factor. It's always good as well to ask questions to see if they have any good insight into their condition, whether they understand what their triggers are, whether they understand about medication, whether they are actually adhering to the medication that they're supposed to be on. And it's always good to get a feeling for what their engagement is like with services. Will they come into the clinic, for example, for a review, or will they need a more of a hands-on approach, whether that's home visits or whether that's something else, a bit more of a hands-on approach. And always good to safety plan with the patient. If they're not too worrying, not too risky, that could be simply asking about their plans for the weekend. But in more riskier patients, it might require a referral to the crisis team, or possibly asking the patient to go to A&E, or possibly getting them sectioned in severe cases. And that is the end of the presentation. Thanks very much for listening. If anyone's got any questions, I'd be happy to answer. And I think there is a feedback as well.
Thank you so much, Miles. That was really informative, a great presentation. The chat is here, so feel free to enter any questions if you have any to ask Miles. But if not, please scan the QR code and provide some feedback. It's always really helpful to get feedback and see what you enjoyed about our sessions and what can be improved for the future sessions as well. And if you can't think of any questions now, feel free to email us on the Mind the Bleep emails if you think of anything later. Okay, thank you. Thanks, Miles.
Thanks very much, Hannah.
Bye, take care.
Thank you.